slide I love seeing and I love talking about. And the slide is this one right, where is it? Right here. Right now, I do have a video just about this slide. That's how important this slide is. The reason why this slide is so incredibly important is simple. It discusses what happens electrically in the heart and the overall effects the heart's electrical impulses has on the contraction. Now, we measure the contraction of the heart by the amount of pressure it exerts. It makes sense, right? Why would there be a change in pressure in the heart? The only reason is because the heart muscles are contracting. So when you see a noticeable increase in pressure, is a sign that the heart muscles are contracting. Then, as the heart muscles are contracting and there's a change in pressure, the last parts right here discusses the change in volume. If you're contracting the heart, aren't you going to move blood somewhere? And if we're moving blood from place to place, we should see decreases as we're ejecting blood from the left ventricle out. And then when it comes back in the next cycle, we should see an increase as well. So this one slide, and then, right, what else do we notice? Is that the electrical component, which causes the mechanical contraction, which is then measured by the pressure, which is then going to cause us to have blood flow. Well, we should be able to also hear any of this, right? Or some of it. So this one slide will discuss, if you understand the slide, you understand the heart, period. So I will come back to that probably in the last, like 10 minutes and just discuss only this slide. Because this slide not only talks about heart and the actual impulses and electrical activity, but it connects that electrical activity with what happens with the pressure changes caused by the muscle contraction. As the pressure changes, it's going to cause movement of blood from the heart towards the heart, out of the heart, and then heart sounds. So let's talk about the very first part, which is, and we're going to take it right here with histology. Now, histology of the heart, keep in mind, and in terms of histology of heart, the heart muscles, and I think we end it right here. All right, so here's what the heart looks like with the atrius removed. And what you'll notice is you have these bicuspid valves, right? On the actually on the right, the bicuspid or mitral, and then on the right side, the tricuspid valve separating the atrium from the ventricles on each side. And then you have thick connective tissue right here. It's incredibly thick connective tissue. It is a non-conducting connective tissue. We'll talk about why that's important in just a second. And you have this thick connective tissue kind of linking all four valves. And what we're going to see is that that non-conducting strong connective tissue is going to be incredibly important because, number one, it allows the valves to be locked in place. It anchors the valve in place. Now, semilunar valves open and close with ventricular contraction and relaxation. These are our semilunar valves, the aortic and the pulmonic valves. Semilunar valves close with relaxation. As they close, blood coming back from the pulmonary arteries, blood coming back from the aorta is then going to sit and close up the valves. As the valves are fully closed, there's no backflow. Perfect. Remember, that's the true function of the valve, is to prevent that backflow. Now, let's talk again about the normal blood flow through the heart. And I know I've mentioned it a couple times, right? Now, if you take a look at these numbers, you would think it goes into sequence, meaning it goes from the right atrium through the tricuspid to the right ventricle. The right ventricle contracts, ejects blood through the pulmonary valve into the pulmonary trunk, into the lungs. In the lungs, the oxygen is going to go into the red blood cells where we oxygenate, and then blood's going to return from the lungs fully oxygenated by the pulmonary valves on each side. Then goes into the left atrium, and then goes past the mitral valve into the left ventricle. Left ventricle contracts, then it goes into the aorta, going through that open aortic valve. You think it goes in sequence like that. In reality, what would happen if it does go in sequence? That's not going to be very efficient. In reality, what happens is number 1 and number 6 occurs at the same time. So as blood is returning to the right atrium from the superior vena cava, from the inferior vena cava, from the coronary sinus, as all that deoxygenated blood goes into the right atrium, blood from the lungs, now oxygenated, is going to go through the left and the right pulmonary veins into the left atrium. So number 1 and number 6 happens at the same time. As blood from the right atrium goes past an open tricuspid valve, blood from the left atrium goes past an open mitral valve into the left and right ventricles. Now, then we're going to contract from the bottom up. As we contract, the ventricular muscles contract from the apex upward. So as you contract the ventricular muscles, if we're contracting from the bottom up, there's a chance blood's going to move up into the atrium. So what we're going to see is as a contraction occurs, you need to close the mitral and the tricuspid valve. As you close those valves, all you've done is close the valves. You need to still develop tension. Remember, there's blood sitting on top of that aortic valve from the last contraction cycle. There's blood sitting on top of the pulmonic valve from the last cycle. In order to open that valve, you need more pressure from below. If there's more pressure from below, then you can pop open that valve. And that's what we're doing right here. The left ventricle and the right ventricle are going to contract together. The right ventricle has to exceed about 90 millimeters of mercury pressure to pop open the aortic valve. The right ventricle has to exceed about 20 millimeters of pressure to pop open the pulmonic valve. Now, that's where I want you to think, right? One has to exceed almost 100 millimeters. This one only 20. Shouldn't the right ventricular muscle and the blood flow occur first to the pulmonary trunk? It's got less pressure to obtain to, right? Here, you just have to get to 20 millimeters of pressure on the right side. On the left side, you need to go to 90, almost 100 millimeters of pressure just to open the aortic valve, right? Shouldn't there be a asynchronous blood ejection? Meaning this one in front on the right ventricle, right, ejects blood first because it has less pressure to go through. It doesn't. And the reason why is the overall amount of myocardial cells. It takes the same amount of time for the thicker, stronger left ventricle to get to 90 millimeters of mercury to open that aortic valve. It takes the same amount of time for the right ventricle with its fewer amount of myocardial cells, just not enough muscle there, right? So it takes more time for this muscle to, or it takes the same amount of time for this right ventricular muscle to get to 20 millimeters as for the left ventricle to get to 90. Why? Well, because of the relative thickness of each ventricle. Left ventricle has more muscles. Because of that, it takes equal amount of times to get to 90 and 20 because of the because of the actual amount of myocardial muscles in each side. At that point, we're then ejecting blood out of the pulmonary trunk, out into the aorta at very similar times. Perfect. So all of this 1 and 6, or 1 and 5 right here, are occurring concurrently together. So as blood goes into the right ventricle, blood's going into the left ventricle. As blood is being ejected to the aorta, blood's being ejected into the pulmonary trunk. They're happening concurrently. Now, what allows us to have this synchronous contractions? We're going to see there's the atria is going to contract first, then the ventricles. The atria is then going to contract second, and then the ventricles. It's always atrial contraction, then ventricular contraction. Atrial contraction, then ventricular contraction. Well, how do we make sure that there's that kind of rhythm? Keep in mind that all myocardial cells, whether they're found on the atrium or on the ventricles, all cardiac muscles are autorhythmic. It contracts by itself. So what happens? And they're easy to stimulate. So what we're going to see is we need to stop the atrias from activating the ventricles. So what we're going to have then is a way to isolate. So then the atrias contract first, there's a little bit of weight, and then the ventricles contract second. Atrias then contract again for the next cycle, a little bit of weight, and then the ventricles contract. So we need to synchronize that kind of contraction. So what we have then is a fibrous skeleton of the heart, plates of dense, tough connective tissue that I first showed right here. These are the plates. These plates have a couple very important functions. Keep in mind, this is not the pericardium. This is inside of the heart. The pericardium is outside of the heart. So this fibrous skeleton system right here is found within the heart muscle itself. What does it do? Number one, it forms these dense fibrous rings so then we can support the valves and it doesn't rip. Think about your aortic valve. Think about how many times you contract the heart a day. How many times you contract it in a week, in the course of a year, in your lifetime. Most of us don't have problems with the aortic valve, especially not until later in life, right? Meaning that for the most part, it worked incredibly well without ripping. One of the reasons why is because of these fibrous rings around the valves. Now, there are people that do have issues where the rips start to occur, right? There are people that are older that might have illnesses early on, right? Rheumatic fever is one of them, where it causes some of these valves to actually become seeded with bacterium, and then it's more likely then to rupture. But for the most part, we don't really see a rupturing of those valves because they're so held tightly in place by these fibrous rings formed by the fibrous heart skeletal system. So one of the functions, support the valves to prevent injury, prevent damage. Second one, provides site for muscle attachment. So then you need an anchor. All muscles need an anchor. In skeletal muscles, you have an origin and an insertion, both usually on bones or other tendons. Well, in the heart, there is no real skeleton. This is not skeleton. This is not calcium phosphate on this collagen matrix. No, it's not like this. It's dense, tough connective tissue. And what it does is it acts like a pseudoskeleton, right? It anchors the cardiac muscles. So then cardiac muscles have a way to kind of, right, anchor itself and contract with force. Have you guys ever tried to pull something or push your car if it's stuck during the winter, right? Your car's stuck in, a bank, or just, might be just stuck somewhere, and you're trying to push. And because there's snow on the ground, there's no place for you to set an anchor. So you can't push off. So what happens? Well, you're not going to be able to move the car even a little bit, right? We need an anchor. That anchor provides traction, leverage, so then we can contract. Same thing with the heart. You need some kind of traction, leverage, so then the cardiac muscles have a way to pull and contract and squeeze. That's one of the functions of the fibrous heart skeleton. The last one is just as important. And I say that for last because it requires a little bit more thought. And that is, it provides electrical insulation between the atria and ventricles. In other words, It allows you to stimulate the atria first and then the ventricles. It's probably easier to understand what it does if it's not there. Let's say you don't have a fibrous skeleton. What happens? Anytime you cause the atria to contract, the ventricles will contract at the same time. There is no synchrony. They just both, all parts of the heart contract at the same time. Well, now there's no real good rhythm, is there? Right? We want atria to contract first, then ventricles. Atria, then ventricles. Without the fibrous skeleton, whenever we cause the atria to contract, ventricles contract immediately as well. So then all 4 heart chambers contract at the same time. Now, it doesn't cause your heart to explode, doesn't cause any of that. It just makes it incredibly inefficient for a muscle contraction to occur. Incredibly inefficient to pump blood out of the heart. And if that happens a lot, you're not going to be pumping blood out and you'll go into ventricular fibrillation. So what we need is something that disconnects the atria from the ventricles. That is the fibrous skeleton of the heart. It acts like an insulator. So then you disconnect the atria. So we can then cause the atria to electrically discharge and then contract first, and then cause the ventricles to discharge and contract second. It allows that normal sinus rhythm to occur. That's what you sometimes might have heard, normal sinus rhythm. Normal sinus rhythm means the atria contract, then the ventricles. Atria, then ventricles. That fibrous skeleton really helps in producing that synchronous contraction. Now, that could be more of a written kind of question. Now let's take a look at the cardiac muscles. And hopefully you guys saw this last semester before we had a chance to, before, you know, the whole coronavirus thing kind of took over. With cardiac muscles, they're striated, meaning they have the same arrangement of myosin and actin. They have the same arrangement of troponin and tropomyosin. Now, we don't have time to really discuss that in our lectures. You need to kind of go over it in 201 if you didn't remember it. I will ask about troponin, tropomyosin. I will ask about actin and myosin. So we can't get away from that, right? Now, if you understood it, it doesn't take us long to kind of review it again. Keep in mind, the reason why they're both striated, skeletal and cardiac, is because you have the same arrangement of actin and myosin produced to form sarcomeres. You have the same regulatory proteins, troponin and tropomyosin, that allows us to stimulate. So then we can, in my 201 class, we talked about how skeletal muscles need to be electrically activated first, and then that electrical activation causes the muscles to then shorten, mechanical shortening, right? This is the exact same thing with cardiac muscles. You need to electrically discharge first. And the reason why that's important is because there's a very big ion that connects what happens electrically to what happens mechanically. The action potential triggered by skeletal muscles, the action potential triggered by cardiac muscles is important because it causes calcium release. Calcium is what binds to troponin and moves tropomyosin out of the way. Normally, actin and myosin are separated from each other because of this protein, tropomyosin. In order for a muscle contraction to occur, we need to move this protein out of the way. That protein only moves out of the way when calcium is released. When calcium is released, it binds to this one, troponin. Troponin, with calcium being present, moves tropomyosin out of the way, allowing myosin's head to interact with actin. When they interact, they pull, and if they pull everything to the middle, shortening the muscle. Same thing here, right? Now, the troponin levels are actually more important. That's one of the ways that we consider the gold standard in the diagnosis of an MI. In an MI is due to a blood clot. What happens? The cardiac muscles start to die. The longer the clot kind of setting in place, the more muscles start to die. The more myocardial muscles start to die. The more troponin it releases. So we should never find troponin in our bloodstream unless we're having an MI. So if you have chest pain, and it does happen in females from time to time, it's uncommon in females under the age of menopause, but it does happen. And when it happens in females before menopause, usually it is misdiagnosed. I had a student a couple years ago now that actually had an MI at 28 years old. It was so uncommon. She looked like she was in good shape. She went to the ER 3 separate days in a row. And only on the third day did they give her a blood test and an EKG. Eventually, on the third day, they checked her blood. Eventually, before the other 2 times, it was all about, some kind of fatigue or some kind of stress, right? The last day she went in, they finally decided to do it, the test. And again, these tests are not hard to do. So I would be very upset about her. And they checked the blood test for troponin levels, which were still elevated, and then an EKG, which showed a couple of things that were, kind of pointing to an active MI. So for her, she survived it. But just by looking at her, I could tell that she had some kind of medical condition, right? I wasn't going to ask. Eventually I did ask. But what it was that she just looked kind of greenish, bluish coloration. All right, she had kind of a slight cyanosis to her. And I could tell just by looking that she might have had something wrong. I thought it was something to do with the lungs, right? Because, it's so rare for women under the age of menopause to have MIs. I can understand that. But yeah, you ladies can. After the age of menopause, it never the probability never increases to a man's probability, but it does increase significantly after menopause. Now, quick review of these muscles. They have intercalated disc, which allows for cell-to-cell communication, meaning that these cell communication, these intercalated discs contains gap junctions. So when we talk about communication within a cell, these cells, I know this is going to sound stupid, but the cells have no eyes, it doesn't have any ears, doesn't have a sense of touch. So how do they communicate? They communicate by passing ions from one cell to the next. That's it. So if I activate one cell, calcium is going to come in. Calcium then is going to flow to the next cell, causing the next cell to depolarize. Then any other cells it's connected to will depolarize as well. This is what makes it autorhythmic. By stimulating one cell, right here, by stimulating one cell, every other cell is connected to. And every other cells, those cells are connected to, will also get stimulated. So it's very important then to regulate which cells we activate first. This is why that fibrous skeleton is so important. Because if we stimulate the atrias and we don't cut off that communication, as soon as we stimulate the atrial cardiac muscles, they will link to other atrial cardiac muscles, which then will link to other ventricular cardiac muscles. So then all of it contracts at the same time. Not good. By having that fibrous skeleton in the heart, we basically disrupt that communication. It's exactly what we want. Then, as we stimulate, we need a conducting system. So then we have this synchronized contraction, something we call normal sinus rhythm. Why do we call it normal sinus rhythm? Because the main pacemaker is your SA or sinoatrial node. So I've just contracted, my heart's relaxed. What happens then? Well, the conducting system allows the electrical stimulus for the next contraction phase. So the pacemaker, the SA node, is the first one that discharges. Keep in mind, if we look at the heart, if we look really closely, Do we see what looks like little shiny metal things here? No, right? In reality, it is just modified cardiac muscles. That's all it is. And the main purpose of these modified cardiac muscle is not to cause a contraction, is to stimulate. That's all. So the first one, the SA node, is called a pacemaker because it paces the heart. It's the first one that actually stimulates, the fastest stimulating area. What we're going to see is as it discharges, the electrical conduction is carried from cell to cell to cell in the atrium. Keep in mind, that goes all the way from the left atrium and the right atrium. It goes from the top of the atrium all the way to the lower parts of the atrium on each side. Now, it doesn't, though, go into the ventricles. Why not? Because you have the fibrous skeleton of the heart. And that insulates the cardiac muscles down here from the cardiac muscles up here. Perfect. Now we can control which region to contract first. With the SA firing, we discharged the electrical component of the heart muscle and the atrium, but the electrical impulse does not reach the ventricles. It's prevented by the fibrous skeleton. Now, keep in mind, all right, there's a difference between electrically discharging it and then a contraction. We measure the electrical discharge by way of an EKG. And we'll talk about that in a second, right? The contraction takes place only after calcium is released. So you need that electrical discharge first that causes calcium release. Then, a few milliseconds later, the calcium is released, binds to troponin, tropomyocin's moved out of the way, then the actin and myosin interact, and then you have this mechanical contraction that is then measured by the actual, force or pressure being felt in the heart. So the cardiac conduction system starts with the SA node, causes depolarization of the atria on the right and the left side, but not the ventricles. But as soon as we kind of contract the ventricles, not discharge it, but contract the ventricles, we will then stimulate a second node called the atrioventricular node. Atrioventricular nodes found in the medial lower part of the right atrium. This node, the AV node, is then going to send an electrical discharge through the AV bundle, atrioventricular bundle, which then divides into the left and the right bundle branches. The left and right bundle branches then transmit that action potential to the left ventricle and the right ventricle. In the process, these smaller Purkinje fibers are the actual fibers that allows you to stimulate the ventricular muscles. And if you take a look, the apex is the closest to the actual bundle. So this is where the contraction starts first. Again, SA node fires causing atrial depolarization. And then eventually, as they depolarize, atrial contraction. Then the AV node fires, sending the signal through the bundle branch, which then splits to the right and the left bundle branches. Left is going to stimulate the left ventricle, right stimulates the right ventricle. Well, the first branch that receives it are Purkinje fibers in the apex, which stimulates the heart at the apex upwards. As it contracts up, the muscles contract, developing pressure. Now there's blood in the ventricles because the atria are contracted already, and you're full. At that point, if we contract, we need to prevent backflow. So we need to close these valves. In a second, we'll talk about the link between the electrical, then the mechanical, and then the heart valves in just a second. Okay, again, SA node, AV to the AV bundles, which splits into the right and left. It is these Purkinje fibers that directly stimulate the myocardial cells. And this one kind of discusses a little bit more detail. right? Again, and this is why we need this conduction system. What happens normally is your atrias want to contract a little bit at a faster rate than the ventricles. If the ventricles, let's say you don't have a functional SA or AV node, if all of it's messed up, what happens? Your ventricles only want to contract at a rate of 20 to 40 beats per minute. That's not a lot. Your ventricles, right, are your main pumps. If they're contracting at this lowered number, you are not going to bring blood in sufficient enough quantities for your body to use. So this conduction system increases the firing rate of the ventricles to 60, 70, 80 beats per minute when you're resting. And when you're exercising, the node can fire even faster, making it 150 beats per minute. So this cardiac conduction system is important to set a normal rhythm. If everything is suppressed, the weird thing is the ventricles fire at a very slow rate. The atrias fire at a much faster rate, right? So we need this conduction system to synchronize the contraction. So then we can slow down the atrial contraction. So then we can increase the ventricular contraction. So then we have an actual match. Perfect. That's exactly what this cardiac conduction system allows us to do. It matches what's happening in the atrium to what happens in the ventricle. Now, right, review the, in terms of the timing, understand that it should make sense, right? SA node sets a pace, it's the fastest to fire, as it spreads really quickly as well. In a very fast 50 millisecond excitation, this action potential triggered by the SA node goes through both atrias and down the AV node, the second node. So this is a very fast stimulation, like a flash, right? Then we stimulate the AV node at the very end of it. But the AV node delays that message for 100 milliseconds. It slows it down. Why does it slow it down, right? Because as soon as the AV node gets stimulated, you'd think we're just gonna stimulate the ventricles now, but it doesn't, it delays it. And the reason why is because you want time for the atrias right here. The atrias going to receive that electrical stimulation. It takes time for that calcium to be released. It takes time for the atrial muscle to contract and then bring blood into, or the rest of the blood into the ventricles. And then you want time for the atrias to relax. That's why there's a delay here. So then you have time for the mechanical part of the contraction to occur in the atrias. Perfect, right? Eventually the delay is over, the atrias contract, is ejected the remaining amount of blood into the ventricles. It's now relaxed for the next cycle. And now the AV node fires, spreads very quickly through the AV bundles, very quickly through the bundle branches, and now you stimulate both ventricles at the same time. Perfect. Now, some of you guys have seen this. This is a picture of your skeletal muscle. This is the electrical conduction in your cardiac muscle. Big difference. If you haven't seen it, especially with this one right here, I'll just go through it real quick right now, and hopefully it'll stimulate some memory, all right? So this is skeletal, this is cardiac. In the skeletal muscle, when we want a muscle to contract, we're gonna release acetylcholine. Acetylcholine causes receptors, acetylcholine receptors to open up. Sodium then rushes in, and if I hit threshold, voltage-gated sodium channels open. So at depolarization, voltage-gated sodium channels open. They open up, sodium rushes in, a lot of it rushes in. As it rushes in, we go from minus 85 millivolts, that's found in a resting muscle. right? When I stimulate the muscle with the release of acetylcholine, then I hit threshold, voltage-gated sodium channels open. Sodium is positive charge. What happens? If a lot of sodium comes in, don't you go from being very negative to being very positive? You do, right? That's what we call depolarization. That sodium influx through sodium voltage-gated channels causes this depolarization. Depolarization is our electrical impulse. That depolarization will then lead to calcium release from the sarcoplasmic reticulum, right? So as you depolarize, the depolarization of the electrical muscle is spread throughout the whole muscle. It then gets conducted to our transverse tubules, which then carries the electrical potential into the muscle itself and allows for calcium release from the sarcoplasmic reticulum. The calcium that's released then is going to bind to troponin, moving tropomyosin out of the way, allowing actin and myosin to interact and contract. That's why the depolarization is important. It causes calcium release. All of the actin and myosin, it's all ready to go. Myosin's head is cocked, it's ready to contract. But there's another protein in the way, tropomyosin. This depolarization phase, the electrical discharge, causes the release of calcium, which then binds to troponin, moving tropomyosin out of the way. That tropomyosin that was blocking the other two proteins, actin and myosin, now it's moved. And now we can contract and shorten. And now also we can relax as well, and the repolarization phase occurs. That's in a normal skeletal muscle. In a normal skeletal muscle, I have a quick up and down release of calcium, and we form a twitch contraction. To have a nice, strong, sustained contraction, I keep stimulating it, multiple twitches, right? I stimulate it one time, that muscle, and I have this depolarization. And as soon as I recover, I stimulate it again, and then again. The more depolarizations, the more action potentials in a short time frame, the greater and smoother the contraction becomes. That's how we get a strong, smooth contraction in skeletal muscle. We activate it, depolarize one after the other after the other. As soon as a muscle recovers, we stimulate it again. We don't wait for it to relax fully. We stimulate it continuously. Do we want that in the heart? Do we want to keep stimulating the heart and keep stimulating it electrically? No, it can cause an arrhythmia. So what we do in the heart is slightly different, right? We in the heart need to sustain a longer contraction. Take a look at the numbers here, right? This is about a half of a millisecond. That's how long this phase for depolarization is. It's actually about from 1 till about right here, maybe a quarter of a millisecond. That's it. That's how short our depolarization phase is in the skeletal muscle. That's not enough in the cardiac muscle. Remember, in the cardiac muscle, we need to go from a blood pressure of 0 millimeters of mercury at rest in the ventricles. So the pressure at rest in diastole of the ventricles is at 0. And in order to eject and even open the aortic valve in the left side, you need to get to about 100 millimeters of mercury. In other words, you can't just have one stimulation and that's enough. You need to stimulate for a much longer period of time. You need to keep activating the muscle. You need lots of calcium to be coming in so that the muscle can gradually contract with more and more force, creating more and more pressure with how long it takes to contract. The longer, the more force you can create, the better it is. Take a look at the numbers here, right? We depolarize and then we stay elevated for almost 500 milliseconds, which is crazy. Here, it was only like a quarter of a millisecond. Here, almost 500 milliseconds. So it's like 2,500 times longer of this action potential phase. The reason why is that we want the muscle to go and create pressure, and it starts off at a very low pressure of 0. And then you stimulate it. As you stimulate it by depolarizing, sodium rushes in. Sodium then sodium goes through the sodium channels, voltage-gated sodium channels, which then causes a little bit of calcium release from the sarcoplasmic reticulum. The difference is this: you don't have enough calcium inside the cell. So the calcium also has to come from outside the cell. Extracellular calcium is required by voltage-gated calcium channels. In cardiac muscle, you have what's called the plateau phase. That plateau phase allows us to electrically stimulate the cardiac muscle for a long period of time. In the skeletal muscle, to have a nice smooth contraction, I need multiple action potentials in a very short time frame. For our heart muscle to develop pressure and tension, we only have one depolarization, one action potential. But that action potential lasts much, much longer, 2,000 times longer. And that lasts 2,000 times longer because of this number 2 region called the plateau phase. That plateau phase is not seen in skeletal muscles, only in cardiac. That plateau phase allows more calcium to come in from the outside. As calcium comes in from the outside, there's more calcium to bind to troponin. And now you keep tropomyosin away from actin and myosin. Those muscles, those proteins, have a longer time frame to contract and create pressure. Perfect. That's what we want. We want to contract and create pressure. The longer we create pressure, the more we go from 0 millimeters of mercury to 20. The longer the plateau, we go from 20 to 60, from 60 to 100, which then allows us to have enough pressure to pop open the aortic valve and to keep contracting. So this plateau phase is incredibly important for the cardiac muscle. Plateau phase allows us to have a very long, sustained contraction that increases the pressure. And it's caused by extracellular calcium from voltage-gated sodium channels. And here's a picture that shows us, right? Here, right away, in blue, right? P means permeability. So the higher this blue line is, and we can see it matches that initial upswing in charge, right? Because it matches it, we know that sodium coming in is what causes our active depolarization phase. Sodium going through voltage-gated sodium channels. That part is identical when we talk about skeletal muscles and cardiac muscles. Then, something not seen in skeletal muscle is calcium, right? As soon as you depolarize, that depolarization from minus 85 to positive 30 is due to sodium coming into the cell, right? Goes up and then goes back down. Well, then what causes this long plateau phase? Calcium. Calcium coming into the cardiac muscle allows us to prolong our action potential. Again, why do we need it prolonged? Is because you need to create tension. You need to go from 0 millimeters of mercury till about 120 millimeters to eject all the blood out. That's a lot of pressure for you to develop. That can't happen instantaneously. It needs to develop with time. And that's what we see here, right? As you develop with time, then we create that pressure. And it's all due to calcium. Eventually, potassium exits. As potassium exits, then we repolarize, which is a sign of relaxation. So we can only contract for so long. Right? Now, differences between skeletal and cardiac muscle physiology. One, cardiac muscles are branched, so you can conduct action potentials from cell to cell. There's greater cell-to-cell communication and sometimes miscommunication. You've heard of people that sometimes have had an arrhythmia, right? That can be caused by having an ectopic beat, where instead of the SA node firing, there's somewhere else in the atria that fires too. And it causes somebody to have an ectopic beat when they shouldn't. Because the cardiac muscles are linked, anytime you stimulate one cardiac muscle, all of the other muscles that it's connected to also stimulates. In terms of cardiac muscles, rate of action potential propagation is slow because gap junctions and small diameter fibers. Again, we don't, we need it to be somewhat fast, but not super fast, right? We're gonna be contracting it for a long period of time. We don't need to stimulate it incredibly fast because it will be contracting for long periods. And then in terms of cardiac muscles, we need calcium from the outside to come into the cell. In skeletal muscles, all the calcium that's required for a contraction, all that calcium comes purely from inside the cell, only from the sarcoplasmic reticulum. That's what we see in skeletal muscles. In cardiac muscles, we'll have sarcoplasmic reticulum, but it doesn't store enough calcium for this incredibly long action potential. Instead then, because you can't store enough calcium, you need calcium from the outside to come in. That's what we call calcium-induced calcium release. Calcium from the outside goes through the plasma membrane, which also stimulates further calcium release from the sarcoplasmic reticulum. Perfect. It aids in the amount of calcium required. Because keep in mind, you need that calcium because you're contracting for such a long time frame. Again, right here you're contracting for maybe a quarter of a millisecond, 0.25 milliseconds. That's it. Here, it's almost 500 milliseconds. It's 2,000% longer. That's a much longer need for calcium. That's why we need calcium from the outside. Right? Now, this other picture is a picture of our SA node. Keep in mind, this SA node is slightly different than what we saw. This is our normal cardiac muscle. You stimulate it, there could be a ventricular muscle. You have a depolarization and a very long plateau phase, right? Which allows you to contract for a very long time so they can sustain pressure. That's different than what we see here. Here, right, take a look. This is your SA node, our pacemaker, and that's it. What we get is, all right, you have one contraction phase, and then as soon as we recover and repolarize, right, at minus 60 millivolts, a small number of sodium channels open. Highlight that. So what happens is there is no resting membrane potential, meaning if I measure your neurons at rest, the outside and the inside of the neuron, when we compare it, the inside of the neuron at rest is minus 70 millivolts more negative than the outside of the neuron. In a cardiac muscle, not the SA node, but in a typical cardiac muscle, when we measure the inside, it's minus 85 millivolts more negative. That's a resting membrane potential. In the skeletal muscle, minus 90 millivolts. That at rest, it's minus 90 millivolts more negative inside the cell than outside. In the SA node, as soon as you hit minus 60, then sodium channels open up. So you hit 60 and that's it, right? You go right back up to minus 59, right? And then we call that the pacemaker potential. Pacemaker potential is due to a small number of sodium channels opening up at minus 60. Then you hit threshold. Now, the rest of your body at threshold, voltage-gated sodium channels open at minus 55. Here is the only part where we see it's voltage-gated calcium channels. Calcium channels open up, calcium rushes in, allowing us to depolarize our SA node. At this point, I discharge the SA node. It triggers a nerve impulse that will then spread into the atrial myocardium. So then it will discharge as well, the atrial muscles will. Eventually, as I trigger it, I recover as the sodium channels, actually the calcium channels close up and potassium channels open. Potassium is going to exit the cell. As potassium exits the cell loses positive charge. As a cell loses positive charge, it becomes more negative. It's -60, voltage gated sodium channels open up. Now we're adding positive charge, getting closer to threshold again. So this SA node right here, there's never a real stopping point. As soon as it gets to -60, voltage gated sodium channels open up, and then we start this process again. That's very unlike every other muscle, right? In every other muscle, it starts at -60, and then you need a trigger for you to discharge it again. Not here, right? As soon as you hit -60, there is no trigger, just other channels open up, right? This little slope is our pacemaker potential. I can increase and decrease heart rate by adjusting this pacemaker potential. If I make the slope very high like this, and I activate more sodium channels here, what happens? Instead of a small number of sodium channels that open, and then a little bit of sodium comes in, you add a little bit of charge until you hit -55. What happens if I open up a whole bunch of it? Right? If I open up a whole bunch of sodium channels, a lot of them open, a lot of sodium comes in. I hit threshold faster. If I hit threshold faster, I'll depolarize faster. And I'll have an action potential faster. Then I have a heart rate that's faster as well. This is how we adjust our heart rate. We adjust our heart rate by increasing the slope, by increasing the sodium channels. Or you can also decrease the slope. Then when you hit -60, less sodium channels open up. When that happens, you hit threshold way over here. What happens? There's a delay in your heart rate. And because of delay, you have less heartbeats every second or every minute, which is good. All right, now let me just go through the EKG and then I'll stop. Right, with the EKG, right, couple things I want you to note is, you guys have probably seen this before. There's no difference between EKG and ECG, right? EKG means electrocardiogram. The difference is the K, usually we see EKG in, the European states. That's it. Same thing, all right? We see waveforms, 2 small ones, 1 huge one, right? The first small one is called the P wave. P wave is a depolarization of the atrial myocardium, meaning the atrias discharge. They don't contract yet, right? They just discharge because they've been electrically activated. So when we see the P wave right here, we know the atrias are in the middle of discharging and becoming active electrically. It is halfway through the P wave do we actually have the atrias start to contract. So the P wave right here is only a sign of atrial depolarization. It is though, and I do want you to highlight this area right here, it is a sign of the SA node function. So P wave indicates a functional SA node. Right? So if you see a P wave and its normal rhythm, we know you have a functional SA node. Now, the QRS complex is the discharge of the myocardial muscles. Again, all muscles need to be electrically activated first. Skeletal muscles, atrial muscles, ventricular muscles, even smooth muscle. They need to be electrically activated first. So what do we see? As soon as the SA node fires, right, the atrius discharge, giving us a P wave. So the P wave is indirectly caused by the SA node. The QRS is ventricular depolarization and then repolarization, right? With the QRS is a sign of a functional AV node, atrioventricular node. In a normal sinus rhythm, P wave first, followed up by the QRS, then followed up by the T wave. Then a P wave, QRS, T. That is normal sinus rhythm. With the P wave indicative of a functional SA node, and then a functional QRS, which is indicative of a good AV node. The SA node causes P, AV causes a QRS, right? The T wave is ventricular repolarization right here, where it discharges and then recovers. Again, P, QRS, T, P, QRS, T. And it is a sign of when the heart muscles discharge. They don't contract until halfway through. So for the atria to contract, it starts halfway through the P wave. For the ventricles to contract, it starts halfway through the QRS, right? So this PQ interval is an interval between when we stimulate the atrias, then it contracts, and then when we stimulate the ventricles, right here. So let's discuss this a little bit. Again, we should always have a P wave, then followed up by QRS, and then a T. So what happens if we don't? Here you see a P wave. Every now and then you see a P, QRS, and then a T. Then you have another P wave, but nothing in between here. Here, small P wave, then QRS and T. Right? This is what we call a heart block. In a complete heart block, that means that you're blocking the cardiac conduction, right? The SA node is still firing. That's why we see all these T waves. But because the SA node is no longer linked for some reason to the AV node, right? Normally when the SA node fires, it will activate the AV node, which then causes us to activate the ventricular muscles, P, QRS, T. That's what we're seeing here, right? SA node, right, triggers, causes the atrial depolarization, also triggers the AV node. The AV node fires, causes an QRS. Then the ventricles repolarize, and then we start the process again. In a complete heart block, for some reason or another, the SA node fires, okay, but the AV node either is not connected to or doesn't discharge properly. So what happens? There's a disconnect between the two nodes, right? The SA node fires still. It's still good, but the AV node doesn't fire at the correct time. So then what we see is that the ventricular muscles start to contract by itself. See how low, right? See how many more P waves? There's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 P waves, but only 1, 2, 3, 4, 5 QRS complexes. So there's a complete miscommunication between the SA node and the AV node. Because of that miscommunication, whereas the SA node should fire, then the AV fires, and then the ventricles will contract. We don't see that anymore, right? The P wave fires, the SA node fires, we see the P wave, but nothing after it here, right? That's what we call a heart block. Right, now we'll talk more about this later on, right? Probably on Thursday. So this is the one that causes death, VFib. Ventricular fibrillation. A normal ventricle will cause us, a normal ventricular contraction will be triggered by a nice, big, sharp, narrow QRS complex, right? Now, a nice, normal, high, very narrow QRS complex means that as soon as the AV node fires, your cardiac muscle in the ventricles are so healthy, it's able to receive that message and it depolarizes as well quickly, right? And it depolarizes very fast. and it's a sign and it indicates how healthy your heart is. So if we have a nice healthy heart, our QRS complex will be very small, very narrow, and in some people, even very tall. That's not bad to have a nice tall QRS. It's really good to have a very, very narrow QRS. That means as soon as the ventricular myocardium receives a message to stimulate, all of them almost immediately stimulates, right? It can only do that if it's very healthy. So you don't see a single P wave here. You don't see a single QRS right here. Not that sharp, very long, tall QRS here. Instead, you have what's called a sawtooth appearance, right? What happens when you have ventricular fibrillation is that instead of heart contracting with strength, it shakes. Because it shakes, it's not going to be ejecting blood out. This is what causes some people to have sudden cardiac death. Now, at MATC, we have AED machines at each corner of our floors. The automatic electrical defibrillator, right? What happens? You put those electrodes on the chest. The automatic electrical defibrillator will check if you have normal sinus rhythm, like we have here. Or it will check if you have VFib. When you have VFib, it will then warn you, right? Remove yourself, you have 5 seconds, right? Why? It's because if you have VFib right here, that person will die. That person is no longer ejecting blood out of the heart. And that electrical discharge from the AED machine will hopefully trigger, right? So then you go from VFib back to normal sinus rhythm. You do not survive VFib. AFib, right, is the atrias shaking. The good thing about AFib, your ventricles are usually not affected. So even though your atrias are shaking, it's not bringing as much blood to the ventricles. As long as your ventricles are contracting and ejecting whatever it gets, you're in pretty good shape. The problem with AFib is this: what happens to blood that doesn't move? Because remember, it's on top of the atrias and it's just shaking. Well, blood in the atrias have a tendency to clot because it's not being ejected to the ventricles. It's just staying there. So what we normally do with AFib is we wait. We give them some blood thinners because we expect there to be a lot of blood clots. Now, we don't shock them back to normal sinus rhythm right away. If we did, we're going to have lots of blood clots sitting on the atrium. They're in AFib, and then I shock them to normal sinus rhythm. What happens? I'm going to move all that clotted blood from the atrium. Now it's going to go to all of it, to the ventricles, and the ventricles are going to eject all that clotted blood to the rest of your body, leading to strokes, leading to pulmonary emboli. Not good. So what they normally do is they give people lots of Coumadin and warfarin, and they wait until the blood clots work. Once they work and they check your INR, then we know your clotting time is a little bit decreased, right? Then we will shock you back to normal rhythm. So if you hear of a friend having AFib and they don't shock them back and you're worried, that's a reason why. All right, now we've already been talking for 2 hours and 45 minutes, so I will stop right here, right? I'm going to talk about the cardiac cycle. So for tomorrow, read the rest of chapter 20, right? Again, I have videos on it. As you're reading it, watch the videos. You guys have any questions? And I'll put these up on as well.